Good morning, respected faculty. Today I am going to present mortality of month July 2026 from Department of Hepatology. First, data of this month and year. Uh, this is the data of this year. Admissions in June 949 and total in 2026 5380. In OPD in June month there were 8500 patients, and in total in this year there were approximately 47,000 patients were seen. This is the data the of procedures done in this year and this month. The mortality, Mr. H, 45 years old male, presented with chief complaints of abdomen pain for last 5 days and decreased urine output for last 3 days. Patient was apparently well 5 days prior when he developed abdomen pain, which was diffuse, which was present in whole abdomen and non-radiating. Patient had no history of any long-term hepatotoxic drugs, any history of blood transfusion or similar illness in past. There was history of alcohol intake, significant alcohol intake, and last intake was 15 days back. Initial assessment in emergency. Patient was conscious oriented. BP was of 133 and 70 with map of 103 without any support. SpO2 was of 99% on room air. Per abdomen was soft, non-tender, and shifting dullness was present. Patient had outside labs with suggestive of SBP with total leukocyte counts of 6900 with neutrophils of 80 with creatinine of 1.29. Labs of our hospital, hemoglobin was of 7 and TLC were 6.49 with INR of 1.84 and ammonia 55 with total bilirubin of 4.18 and creat of 1.3. On initial examination, IVC was 16/12. VBG was done in emergency with PO2 of 70 and PCO2 of 34 with lactate of 1.2. Working diagnosis of portal hypertension, non-bleeder, CLD ethanol with decompensated ascites with current issues of SBP and AKI of KDIGO 1 was made. Day 1, patient was shifted in ward. Patient was vitally stable and maintaining of SpO2 of 97% on room air. Ascitic fluid showed TLC of 330 with neutrophils of 40 and protein of 2.08 with AD of 19. Patient was started on appropriate antibiotics and other supportive measures. Diagnosis was of portal hypertension, non-bleeder with residual non-bendable varices, CLD ethanol with decompensation ascites and with issues of partially treated SBP with AKI of KDIGO 1. From day 2 to day 5, patient was stable vitally and was maintaining saturation on room air with no significant event was happened during this period. Other investigations was also done which showed hepatitis B and C non-reactive and sepsis screening, blood culture, urine culture and ascitic fluid culture overall negative. Day 6, patient was shifted to ICU in view of shortness of breath. When he came in ICU, his heart rate was 106 per minute, BP was 150/70 with map of 90 without any support. Respiratory rate was 24 per minute with SpO2 of 97% on 4 liter oxygen. In chest, there were bilateral rhonchi were there. ABG showed pH of 7.4 with PO2 of 88 and PCO2 of 26 with lactate of 1.8 and bicarb of 16.5 and 16.4. Initial assessment was done and that showed ECG of normal, 2D echo was also normal, TROP-T also came normal. Respiratory viral panel was sent immediately and it came out to be influenza A positive. Sir. He was started on oseltamivir 75 mg per oral BD. This was his X-ray on day 6. CT was also done. HRCT thorax was also done, which showed mild bilateral perfusion with passive subsegmental collapse of underlying lungs. There were few GGOs were also seen. On day 10, patient had worsening acidosis and shock. He was attendant were counseled and advised for intubation. Initially, attendant refused for intubation. So patient was managed with NIV. Patient also had decreasing urine output. Again in the evening, attendants were counseled again in evening for ventilator. Then they agreed for a ventilator. So patient was intubated on day 10 in evenings. These are the X-rays done on regular basis. We showed gradual worsening of X-ray. Sir, this one of last day, sir. This was the this were his vitals from day 1 to day 11. Initially, patient was maintaining MAP without any support. Gradually, patient developed shock, and he was started on NORAD 10 with VASOP 2 on day 6, which gradually worsens, and we have to increase NORAD support, and also phenylephrine was added on day 10. Urine output decreased from day 1 to day 11 from 30 to 5 ml per hour. Lactate was showed gradual worsening from 1.2 to 12.7. Bicarb also decreased from 22 to 11.8. Procalcitonin initially was in normal range, but on last day it was gradually increased. IVC guided fluid was given to the patients. His labs, initially his create was of 1.3, which gradually improved, and bilirubin was 4.18, and INR of 1.84 initially, then it increased to 1.9. On day 10, in view of worsening shock, again 2D echo was done that showed normal cardiac, normal systolic and diastolic function with anti-proBNP of 800. On day 11, patient had worsening acidosis and shock, which later patient succumbed to sir, and declared dead on day 11, sir. Sorry, sir.
So not respond to anything, sir. Only influenza positive. But is rapid shortness of breath being shifted, then never intubated. We are not able to find any cause, sir.
So influenza is known to give rise to complications and give features like ARDS and cause death, like what was there in 2020, 2009 pandemic. But in the X-rays, that kind of a feature is not shown. Yes, sir. That's why I'm not sure whether the lung is the cause for death. So I don't know whether you have taken postmortem. Did you take postmortem biopsy of liver and lung and other organs?
No, sir.
Sure.
100%. 100%. Sorry, sir.
Ventilator setting after being there. Ventilator.
नहीं mentioned. Not mentioned, sir.
नहीं, but idea थोड़ा बताओ ना कितने में था?
Sir, on day 10, when he was intubated, FI2, we were not able to decrease FI2 from day of intubation
So that is
to
what
day
means
of
that
death.
this type of X-ray, what is effort is always requirement is 80% and 100%.
No, sir, there was no history of. We did, sir, sepsis screening also that came out to be negative.
देख रहा
And
Procal chart देखो Procal. Yes, sir. He is having even day 6 intubated lactate was 2.3, Procal was 0.5. But in day 10, he has shown. No, but this is the one day only, na? The patient died on day 11, day 10, Procal is 0.3, then next is 30. But on day 10 also his FiO2 is 100%, inotrope is dual, Nora 20. X-ray is not so bad, but FiO2 requirement is 100%. No,
Yes.
that's a terminal event.
as
That is
post
that is a
last
terminal
day, sir,
only.
this was.
So
Yes, sir. These were the, sir, three patients. All three had, sir, this influenza A positive with respiratory symptoms. Out of three, two were became stable, sir, and shifted to the ward. All had, sir, shortness of breath with influenza A positive, sir. All had negative, not vaccinated for influenza A with similar underlying disease of CLD, decompensated CLD. There was a difference of, sir, MELD and CTP. This Mr. H, who died, had, sir, MELD of 21 and CTP of 12C. Mr. V, who was shifted, had MELD of 18 and CTP of 9B. And Mr. K, who also shifted, sir, ward, had MELD of 15 and CTP of 9B. All three had similar risk factors of age, more than or equal to 45, AKI, and initially poor PF ratio. All were given oseltamivir 75 mg BD from day one, sir. These are X-rays of all three patients, sir. The last one had massive pleural effusion on right side. It was later X-ray, sir. ICD was inserted. So these two patients were shifted to. The only difference was the first who died had higher MELD and CTP score, sir.
any long infiltration is more. So it is viral pneumonia or anything else that we have to know, because his Procal was normal, but he's having high FiO2 requirement.
Yes, sir.
Then he develops the sepsis. So the new term of viral pneumonia, viral sepsis, whether it is the cause or no, we don't know.
Sir, PCT can be risen due to other factors also, like shock or
Any doctor, it is only 12 hours difference. It is the day 10 it's 0.5 and day 11 is 30. So hardly 12 hours difference. So any person going terminal event, high inotropic requirement NORAD of 20. So this has less significance. Everybody know that when Procal high, that is sepsis, but there is not a sacrosanct of only to develop in a period of 12 hours.
initially PCT was normal, which also suggests
For 3
a
days,
viral
it was normal.
sepsis. We escalated antibiotics accordingly, but there was improvement in his clinical condition, sir. Yes, sir. Anti-proBNP was slightly higher, but echo was normal. On day 10, when he was intubated, we did echo again, and TROP-T also done. That's so normal, sir.
Yes. I think that the paralysis medical practice the patients, the relatives, we should take long
Yes, sir. Yes, sir. हाँ सर थोड़ा सा so it is a diagnosis on clinical features. Most patient has fever, myalgia, and respiratory symptoms. Like in our patient, he had some respiratory symptoms. This is clinical manifestations in patients who are cirrhotic and who are vaccinated or unvaccinated. This showed unvaccinated patients had more symptoms in form of fever, cough, sore throat, myalgia, and diarrhea. Who are vaccinated have less symptoms, sir. And the other table showed the who were unvaccinated had more decompensation, more oliguria, altered consciousness, and uncontrolled ascites with SBP, and so who are unvaccinated had more symptoms and overall disease deterioration, clinical deterioration. So, हाँ सर सेम मोर्टिलिटी तो सेम है सर. लीवर पेशेंट सर. जी सर. सिरोटिक सर. Diagnosis, we had different tests: viral cultures, DFA test, serological assay, rapid influenza diagnostic test, and CBNet based test. This multiplex PCR done in our hospital. It has sensitivity of 95% and specificity of 100%, sir. Factors associated with mortality in cirrhotic patients: age of more than 45, hepatic NSAF of grade of more than 2, serum bill of more than 8, and PaO2 upon PF ratio of less than 200 with INR of 2.5. This patient had age of 45 and poor PF ratio, sir. Viral influenza increased the risk of decompensation in cirrhotic patients. Influenza can cause direct hepatocyte injury or secondary to immune damage. In a study done by Madhumita et al. In 22 patients of CLD with influenza, 18 patients died with pneumonia and ARDS.
80% mortality, sir, influenza with advanced disease.
Yes, sir. Yes. These are risk factors again, sir. Age, encephalopathy, bilirubin, creatinine, PF ratio, sir. Cirrhosis among patients with influenza was associated with higher mortality rate of 5% compared to 1.8% patient without cirrhosis, sir. Treatment, sir. All patients received standard intensive respiratory and organ support measures. Glucocorticoids were not administered to any patient. All patients started on oseltamivir 75 mg BD within 24 hours of admission in ICU, and broad spectrum antibiotic to prevent any secondary bacterial infections. Indications of ventilator in these patients: severe respiratory failure, failure to achieve saturation more than 90%, and ventilatory settings were PC pressure control ventilation with tidal volume of 6 ml per kg with PEEP of platelet pressure of 30 to 35 with open lung strategy. So, vaccine, rationale in CLD, precipitates decompensation and bacterial superinfection. It reduces hospitalization, and ATS, ERS recommend annual vaccine, sir. Then it prevents decompensation. If patient is not vaccinated, then it Vaccination prevents the decomposition. These are vaccines, trivalent and quadrivalent vaccines. And quadrivalent influenza vaccine includes R3 strains, strain A, Victoria, Croatia, and B, Australia antigen, plus B. Sir, these are recommendations for vaccine, sir. Every serotic patient should receive annual vaccine, sir. Thank you, sir. Thank you, sir.
Good morning, everyone. I am Dr. Surya Pratap from the Department of HPB Surgery. For the month of July 2026, we have total 17 transplants were undertaken. All of them were live donor liver transplants, with 11 occurring in adults and 6 in the pediatric population. From January to July 2026, a total 103 transplants occurred in the department with 5 DDLTs and 98 LDLTs. You can say the overall mortality for till July 2026 has been up of 10.4%. Elective surgeries for the month of July 2026, total 77 surgeries were undertaken, with 40 being laparoscopic cholecystectomies and 2 being extended cholecystectomy. 3 hepatectomies were done, and 4 hepatogenostomies were done. 6 incision hernia repairs, 1 Whipples and 3 Whipples and 1 HPD was done. Splenectomy was done in 1 patient, 2 CBD explorations, and 1 lap appendectomy was done. 1 Kasai portal enterostomy, 2 inguinal hernia repairs, and 2 umbilical hernia repairs were done. Ileostomy closure was done in 2 patients, with diaphragmatic hernia repair in 1. Lateral pancreatogenostomy, 1 patient. Hydatid cyst evacuation was done in 2 patients, with lap cyst deroofing and open cyst deroofing 1 each. And one patient was operated for hilar cholangiocarcinoma. Trial dissection was done. The patient turned out to be unresectable. 2 small minor procedures, including lymph node excision and drainage of perianal abscess, were done in the department. 15 emergency surgeries are done, including expedited laparotomy and isolysis. 1 expedited laparotomy lavage was done for bile duct injuries and bilioma. 3 gastric perforation repairs were done, when 1 sigmoidectomy with colocolic anastomosis, and for the same patient, colocolic anastomosis was done in view of leak. Emergency surgeries included secondary abdominal closure were done in 3 patients. Expedited laparotomy with cement for hemostasis was done in 1 patient, and 1 Bagato placement was done. Tracheostomy was done in 3 patients. For the month of July 2026, mortalities included a patient, Mr. AKD, 49-year-old male patient. The patient underwent liver transplantation in September 2025. He was poor drug complaints in view of financial constraints. He came to us with a deranged liver function test. He underwent 2 ultrasound guided liver biopsies with showing acute cellular rejection. He was given on MPS pulse therapy and bevacizumab therapy, but the patient developed septic shock with bilateral bronchopneumonia. He had severe graft dysfunction in view of sepsis, persistent coagulopathy, and chronic rejection was present. Patient, 35-year-old male patient, patient of severe acute necrotizing pancreatitis with walled off necrosis. He underwent CT guided percutaneous catheter drainage of peripancreatic collection twice on 9th of June and 16th of June. And he was transferred to Department of Surgery, underwent diagnostic laparoscopy with laparotomy with diversion ileostomy. Later developed hematochezia, and the patient underwent tracheostomy. He died with septic shock with multi-organ dysfunction with ARDS, with recurrent lower GI bleed, patient recurrent lower GI bleed and sepsis-induced liver dysfunction. 29-year-old male patient, he underwent liver transplant on 9/6. Patient Virendra Tomar, a CLD HBV patient, he underwent liver transplant with portal vein thrombectomy. This was another mortality that occurred, which I'll be discussing now. Aish Tripathi patient, case of CLD AIH with MELD of 18. He underwent liver transplant on 6th of July 2026. Intraoperatively, he had massive blood transfusions with portocouple shunt was performed. He also developed intraoperative arrhythmias. He died in view of hematogenous sepsis with refractory septic shock. He had cardiac dysfunction with ejection fraction of 30 to 35% that developed postoperatively, and there was severe sepsis-induced graft dysfunction. Patient Virendra Tomar is a 47-year-old male patient. He was admitted on 2nd of July 2026 in under surgery department, and he has a known case of diabetes mellitus and underwent hemorrhoidectomy 10 years back. He presented in 2020 for the first time with fever and was diagnosed with HBV-related chronic liver disease. And liver biopsy was done at in the same year for liver and diagnosed with cirrhosis. Till 2022 to May 2025, he was on regular follow-up. He had portal vein thrombosis, was put on anticoagulation therapy. And in October 2025, he developed ascites and was managed conservative diuretics. Since February 2026, the patient has himself stopped taking antiviral therapy with 3 months prior that occurred 3 months prior to the worsening of jaundice. 3 months later, he developed persistent jaundice and had a history of alternative medicine intake. He presented to ILBS on he was admitted on surgery, but he presented 1.5 months back to ILBS with abnormal distension, refractory ascites. He underwent ultrasound-guided pigtail insertion for ascitic tapping. He was managed medically with antibiotics, albumin replacement therapy, terlipressin, and he had developed hepatic encephalopathy and had anti-encephalopathy measures. He was evaluated for liver transplant, and his wife came up as voluntarily as a living donor, and he was evaluated as per institution protocol and cleared for surgery. Preoperatively, the patient, as you can see, the HMV DNA log 4 was the log 4 on the 20th of April. That was prior to him stopping medication. He was restarted on medications, and then by the time of surgery, his DNA was only 24. CCT done on mesh revealed complete occlusive thrombosis with involving the main portal vein, right portal vein, left portal vein, and up to the splenic vein, up to the near the hilum. And procoagulant workup done showed a deficiency of antithrombin 3 and protein C. So diagnosis of CLD HBV was made with portal hypertension, upper GI bleeding with last endoscopy done on 23rd of May. He had grade 4 adult portal vein thrombosis and antithrombin 3 and protein C deficiency. Sapna Devi is the donor. She is 46-year-old female patient. Is related his wife with history of LSC has done. Ultrasound done was normal with an LA of plus 7.15 and FS was 219 by 3.7. Volumes were adequate with right lobe blowing 715 and left lobe 589. Artery was classical with segment 4 arising from the RHA with early division of the right hepatic artery was there. Type A portal vein and RHV was no RHV was there and one MRCP was there. MRCP type 1. Preoperatively, these are the problems that we encountered in the patient. He has a decomposition liver disease, he has portal vein thrombosis of ADL4. The patient had very recent hospital admissions for needing multiple LVCs, PCT drainage, and preoperatively hepatic encephalopathy of grade 2, and prolonged pre-transplant hospitalization was present. Intraoperatively, the patient had 6 liters of ascites. The liver was grossly cirrhotic, shrunken with rounded margins. Gallbladder was distended. Multiple collaterals were present in hepatoduodenal ligament, perigastric and perisplenic region. Arterial anatomy was classical and portal vein 10 mm. Hepatic veins showed normal anatomy. The reconstruction was done. Intraoperatively, there was one RHV was seen that was an anastomosis of the recipient IVC. Graft RHV and neo-MH was anastomosis of the recipient RHV orifice. Portal vein, graft right portal vein to middle portal vein of the recipient, and graft RHA to recipient RHA. It was a 2-duct 2 anastomosis with right posterior sectoral duct to the RHD of the patient and right anterior sectoral duct to the graft to the recipient left hepatic duct. Intraoperatively, left renal vein ligation was done in view of a shunt and portal vein thrombectomy was done. The anapatic phase was 77 minutes with a cold ischemia time of 127 minutes and warm ischemia time of 37 minutes. Graft type was 720 grams with GRWR 0.96. In view of portal vein thrombosis, there was a massive blood loss and massive transfusion protocol was initiated with 10,000 ml of blood loss. 21 units of PRBC, 11 FFP, 11 crayon, 1 SDPC was transfused. Outflow, post-operative outflow, triphasic outflow in pattern was seen in both the outflows. PSV was 42 with a flow of 1.8 liters. In the hepatic artery, PS was 32 with an RA of 0.71. Post-operatively, on post-op day 0, the patient underwent intraoperative challenges were, as we mentioned previously. He was shifted to ICU on mechanical ventilation on dual inotropic support. Post-op day 1 failed PSV trial due to the patient had persistent inotropic support and in view of hemodynamic stability was continued on mechanical ventilation. He developed low-grade fever on post-op day 1. Preoperative cultures, blood culture showed E. coli, was sensitive for Ilores, phosphomycin, colistin, and drain culture also showed E. coli. ET aspirate done on the day showed filamentous growth of Aspergillus fumigatus. Based on the sensitivity, antibiotics were upgraded and the patient was started on dual antifungal therapy. The patient in view of preoperative HE, serum ammonia level was done, we showed 151. He was extubated successfully on post-op day 2 and started on NG feeds. But in view of a poor sensorium with inadequate respiratory effort, he was present. He required non-invasive ventilation. In spite of non-invasive ventilation, the patient had worsening respiratory distress. He was re-intubated and patient there was persistent coagulopathy was present. So tech-based components, tech-based corrections were given. Blood and drain culture repeated showed a still MDR E. coli. The ET and ET aspirate galactomannan levels was 4.02 and KOH mount of that same aspirate showed no fungal elements despite of that. CMV DNA was positive, less than 200 copies per microliter. Repeated failed. The patient was trying to wean off the ventilator, but there were repeated failed attempts. There was persistent septic encephalopathy was present, and high vasopressor requirement was persistent. In view of need for prolonged ventilation, the patient underwent tracheostomy. On post-op day 7, the patient had severe transaminitis. CCT abdomen was normal with good portal flow, good enhancement. There was no vascular complication was identified. The patient was suspected to have acute graft dysfunction rejection and was started on low-dose pulse steroids. HRCT done in the same sitting showed bilateral pulmonary consultations and bilateral pleural effusion with right more than left. Infectious workup was done to rule out any other cause of transaminitis, but all of them remained negative. HRCT of the both the artery was visualized normally with a good enhancement. On post-op day 8 to 10, the patient had persistent graft-induced sepsis-induced graft dysfunction. Severe coagulopathy was present, and on tracheal toilet tracheostomy toileting, there was a pulmonary hemorrhage was identified. Tech-based corrections were continued. By post-op day 9, the patient had AKI with oliguria. Nephrology consultation was taken, and CRRT was initiated. On post-op day 11, the patient had progressive hypoxemia and hypercarbia. FiO2 requirement increased to more than 100% with refractory septic shock. Multi-organ dysfunction was present. As you can see, the X-ray, there was complete opacification was seen. By on 15th of July to post-op day 12, the patient developed cardiac arrest at 6:35 p.m. He was tried to resuscitate, tried to be 3 cycles CPR was given, but despite measures, the patient was declared. We identify the cause of death to be fungal pneumonia with pulmonary hemorrhage, and second cause of hematogenous sepsis with severe sepsis-induced graft dysfunction when acute kidney injury, with contributingly CLD, HBV, and type 2 diabetes mellitus. The problems that we have identified in our patient include a massive intraoperative blood loss, MDR E. coli septicemia, and possible invasive pulmonary aspergillosis and severe sepsis, early graft dysfunction, persistent coagulopathy with pulmonary hemorrhage, respiratory failure requiring reintubation and tracheostomy, failed to wean off from ventilator, refractory septic shock, and multi-organ failure leading to death of the patient. Fungal pathogens have been known to cause account for around 11.5% of all the infections in transplant patients, with studies showing a range of 5 to 42%, with mortality reaching up to 80% in some studies. Longer ICU stays and prolonged mechanical ventilation are one of the known risk factors for fungal infection. Invasive fungal infections after liver transplant most commonly include candidiasis, and highest mortality causing organism will be aspergillosis. Some of the risk factors that have been identified in studies showed preoperative hospitalization and need of broad spectrum antibiotics in the last 90 days, MELD score of about 30, presence of serum creatinine of more than 2, and fungal pre-colonization. Intraoperatively can be a donor-derived infection in cases of split liver transplant. Prolonged operative time of more than 10 hours, need of massive transfusions, high urgency transplantation, and patient underwent Roux-en-Y choledochojejanostomy. Post-operatively, renal replacement therapies, early retransplantation, any multiple surgeries and re-laparotomy, CMV, viremia, these have been known to cause, these patients known to have been higher risk for fungal infections. There is a preventive strategy for antifungal prevention strategies after liver transplant, universal prophylaxis. All liver transplant patients immediately after transplantation. Targeted prophylaxis include only to high risk patient, and preemptive therapy for if there is presence of a preoperative fungal colonization or a positive biomarkers. This is given for selective close surveillance patients. The high-risk patients which generally have encountered include high MELD score, acute liver failure, multiple surgeries and reoperation, massive blood transfusion, preoperative broad-spectrum antibiotics, mechanical ventilation, prolonged ICU stay, and CMV infection. And the recommended coverage is for Candida and Aspergillus. Antibiotic prophylaxis in liver transplant patient studies have shown that they have decreased the risk of proven invasive fungal infections. They reduce the incidence of fungal infections, superficial fungal infections, and fungal colonization. With systemic prophylaxis, mortality due to fungal infection is significantly reduced, but there is no reduction in the overall cause of mortality, and no reduction in the incidence of Aspergillus invasive fungal infection. Most commonly used drug is fluconazole for Candida. In high-risk patients, we use Candida plus some and activity with anti-Aspergillus activity like micafungin, caspofungin, and idursulfungin. When the risk of Aspergillus is very high, we can plan for voriconazole and liposomal amphotericin B, keeping the patient renal condition and profile under view. Key messages from this patient will be the invasive fungal infections remain the deadliest infections after liver transplant, with the mortality ranging from 25 to 80%. And most infections occur during the early post-operative period. Delay in diagnosis marks one of the outcome, and prevention is seen to be more effective than delayed treatment in these patients. Thank you. Yes. Sir, the patient had a significant job alterations. As I have seen, this patient had significant job alterations post transplant. Sir, he is from Madhya Pradesh, I think, and the patient when he came to us, his complaint was he has not taken immunosuppressant therapy for the past 20-25 days because of financial constraints. We even admission for here, it took a time for us because the patient was unaffording. We could not Ayushman approvals were pending and all. He is a patient admitted under Ayushman initially, but family he had even during transplant also he had familial constraints were significantly present during transplant. Yeah,
Financial counseling is also very important, whether he will be able to afford immunosuppression or not.
yes.
Okay,
Thank you.
Good morning, everyone. Today I will be presenting the morbidity and mortality for Department of Interventional Radiology for the months of April to June 2026. This is the statistics for the procedures performed by us. We performed 14 tear procedures, 28 TACE, 40 microwave ablations, 9 TIPS, 1 fistuloplasty, 16 DSA embolizations, 60 TGLBs, 108 PTBDs, and 2,000 more than 2,000 USG screenings. Our mortality for this period is a 61-year-old male patient who was an alcoholic with cirrhosis and presented to emergency with altered sensorium. We performed SG catheter insertion in the right internal jugular vein. However, there was a right common carotid artery pseudoaneurysm formation with hypovolemic shock, for which we placed endovascular stent grafts in the right common carotid artery. However, the patient could not be revived and succumbed to death due to refractory hypovolemic shock. Our morbidity for this period includes a 45-year-old male patient with right lobe liver abscess, and a USG guided percutaneous catheter drainage was performed, and follow-up CT showed right-sided empyema, for which a USG guided ICD was placed for the pleural fluid diversion, and gradually there was resolution of effusion and the patient improved. Another morbidity is a 39-year-old male patient with a query of liver graft dysfunction, for which a USG guided percutaneous liver biopsy was performed, and subsequently the patient developed an intrahepatic hematoma. For this, we performed conservative management with serial USG monitoring, and the hematoma resolved subsequently. Another is a 56-year-old female patient with CAGB and primary confluence involvement. Left PTBD and USG guided percutaneous liver soil biopsy was performed. There was development of perihepatic hematoma at the site of PTBD insertion and an AV fistula between the right segmental artery and right hepatic vein. For this, coil embolization of the AV fistula was performed, followed by serial monitoring. However, the patient could not be followed up as the attendants took the patient against the medical advice. Another is a 48-year-old female patient for which pleural tapping was done, and an iatrogenic pneumothorax developed, for which we placed an ICD, and followed by which the lung expansion was full and the drain was removed subsequently. Another is a 35-year-old male patient with severe acute necrotizing pancreatitis. We placed a CT-guided PCD insertion and upsized it later on, following which colonic injury developed, for which the patient was operated. This is the mortality case from our department. It was a 61-year-old male patient which presented with altered sensorium due to CLD ethanol related with portal hypertension and was decompensated with ascites, acute variceal bleed, and was in hepatic NCAF. He has hypertension, and the management plan was on day 20 of the admission, the patient was becoming restless, agitated, and was not obeying commands with deranged LFT, KFT, and severe coagulopathy, and developed a repeat upper GI bleed, for which upper GI endoscopy and EVL was done. The patient was shifted to HDU and was advised SLED. On 11 July 2026, the patient was highly uncooperative during SG catheter insertion, and subsequently an inadvertent puncture of the right carotid artery was done. A pseudoaneurysm formed. However, it was compressed for 20 minutes, and on repeat USG, we couldn't find any active bleed. So the SG catheter was inserted in right IJV with tip in the right atrium, and the patient's vital was stable post the SG catheter insertion. The SLED was started at 5:30, and 2 hours later, the patient developed shock and right neck swelling. On repeat USG examination, there was a pseudoaneurysm of right common carotid artery with active ooze, and the patient was in shock with lactate of 4 and NORAD of 8 with blood pressure of 100/70 and pulse rate of 122. So the patient was subsequently shifted to liver ICU. At 8:30 p.m., 2 units of PRBCs were transfused, and the patient was intubated and put on mechanical ventilator. And the patient was taken up for DSA angiograms at 11 July 2026 at 11:30 p.m. And this is the angiographic run, and we can see the active extravasation. And another point, there is active extravasation, following which we placed covered stents, and the post-stenting angiogram revealed no active extravasation. The vitals improved post-stenting from and the noradrenaline dose decreased from 30 to 20 in trop, and the patient was shifted to LICU for further monitoring, and Rotem-based correction for coagulopathy was done, and multiple blood products were transfused. These are the serial monitoring of lab values and hemodynamic status of the patient. The inotrope requirement increased from noradrenaline of 8 to 30, and vasopressin 2.4 and phenylephrine 5, and the patient deteriorated clinically with the increased requirement of inotropes and increasing lactate values. There was a persistent shock despite triple inotrope support, and the patient developed sudden onset bradycardia with hypotension followed by cardiac arrest. The CPR was started, but the patient could not be revived, and the cause of death in this case was refractory shock and MODS. This is the data from a recent article which states that mechanical complications during CVC insertion in the in the IJV include arterial puncture, which has incidence of 6.3 to 9.4%, hematoma formation, and pneumothorax. The risk factors associated with mechanical complications include patient-related, like comorbidities including coagulopathies, anatomy, restlessness, anxiety, or lack of cooperation, patient positioning, or catheter-related, especially at the site of cannulation, the catheter type, length, and size, operator-related, operator experience, lack of operator training, number of attempts, lack of use of confirmatory modalities, and environmental factors like availability of appropriate equipment or emergency placement. For prevention, we have to be careful before the procedure, during the procedure, or after the procedures. Before the procedure, we have to ensure appropriate operator training, and risk factors we have to identify like large caliber catheters, patient anatomy, inexperienced operator, emergency placement, and compromised procedural settings. And we have to use catheter type and venous access site as clinically appropriate. IGV, when able due to increased risk of complication with subclavian and femoral sites, and identify surface landmarks. For upper extremity lines, approach from the right side and choose smallest caliber catheter as possible. And we have to consider correcting coagulopathy before the catheter insertion with optimal patient positioning, and confirm completion of checklist and full stop timeout. During the procedures, we have to provide appropriate sedation or anesthesia for patient, employ dynamic ultrasound and secondary confirmatory techniques, and use Seldinger technique with limiting the total number of attempts by single operator to less than 2. In case of anticipated difficult catheter insertion, we should use most experienced operator and consider 2 operator placement, and with fluoroscopy, transesophageal echo, and collaboration with auxiliary teams. After the procedure, we have to confirm the catheter tip positioning by chest X-ray, imaged echo or fluoroscopy, and order a CT scan if there is a concern for extravenous access, and consult vascular or cardiothoracic surgery emergently if extravenous access is suspected. This is the management algorithm for the inadvertent arterial cannulation. If the arterial injury is suspected, we have to confirm the arterial injury, for example, by pulsatile flow, hematoma formation, arterial pressure or waveform, blood gas analysis, or imaging and we have to observe the patient for problems with airway and breathing. To see the extent of injury, if only the needle or guide wire was inserted, we have to see if the artery could be compressed easily, and if it can be compressed, we have to remove the needle and guide wire and provide manual compression for 15 minutes with follow-up imaging to assess for complication. If the artery cannot be compressed easily, we have to check if the endovascular repair is possible and follow up with the endovascular repair. And if it is not possible, we have to follow up with surgical repair. And if the introducer or the catheter was also inserted, we have to see for endovascular repair or surgical repair, whichever is possible. These are some case reports in which the common carotid artery pseudoaneurysm was treated with a stent graft, and they state that it is a minimally invasive method of using a covered stent to treat a pseudoaneurysm to avoid the technical difficulties associated with traditional open surgical repair. The endovascular management options include covered stent placement because they seal the arterial defect, maintain cerebral blood flow, and provide immediate hemostasis. Other options include coil embolization. However, it cannot be used for internal carotid or common carotid artery, and vascular closure devices. However, their use is still off-label for management of carotid artery complications. Thank you.
How could have we prevented this in your patient?
So we could have provided the appropriate sedation for the patient before the procedure.
Sedation is very important.
Yes, sir.
Patient is agitated, you sedate him.
Yes, sir. Yes, sir. Ultrasound guided cannulation was performed, but when we recognize, but the patient moved suddenly during the puncture, so it went into the carotid artery. As soon as we recognized it, we removed and compressed it. Sir, 18.
Patient coagulopathy.
Yes, sir. INR was 2.6 at the time of insertion.
Normally, 18 gauge catheter should not cause such
Yes, sir.
problems. So, what could be the reason for leading to such a big pseudoaneurysm in this patient?
So most likely the coagulopathy of the patient.
Are there any recommendations for preventing the pseudoaneurysm in such patients? Would you have given pressure for a longer period?
Yes, sir. Normally, it is recommended to compress it for 15 minutes, but in coagulopathic patients, they usually suggest for 20-25 minutes.
You didn't compress for 25 minutes, isn't it?
Around 20 minutes we compressed, and then we checked on ultrasound. There was no active ooze at that time.
I don't know what are the recommendations in such patients, but in cardiac surgery, if you puncture an artery by a needle size more than 7.5 F, the surgery is postponed, and because heparinization is likely to lead to further complications in these patients. Now, here the patient is already coagulopathic. So are there any existing recommendations in case you puncture the artery in a coagulopathic patients?
No, sir. As such, they are taught, but they are just suggested algorithms only.
This is an avoidable complication. Now, this
Yes, sir.
should not happen. If the puncture is arterial puncture is a known complication, commonest complication, but it should not lead to such type of death. Now, could it have been postponed? You could have done it next day. Ah.